Now my pleasure to introduce our first speakers. Dr. Erica Pon is the Deputy Director of the Center for Infectious Diseases and the State Epidemiologist, as well as the Acting State Public Health Officer. Prior to joining CDPH, Dr. Pon served in several positions at both the Alameda County Public Health Department and the San Francisco Department of Public Health. She is a clinical professor in the Department of Pediatrics, Division of Pediatric ID, yay, at UCSF, and she maintained her clinical work at Benioff until 2019. Since then, of course, she's been a little bit busy. Dr. Pon has been an amazing leader throughout the pandemic, always following and reporting the data very clearly. Having been on several calls with her, I was, of course, impressed with her knowledge, but also really impressed with her willingness to hear multiple points of view through some rather thorny, I would say, COVID-19 topics. So thank you, Dr. Pon, so much for being here. And I'll go ahead and give Dr. Schechter's introduction as well, and then let you both get started. Dr. Rob Schechter has been a medical officer with the California Department of Public Health Immunization Branch since 2003. Dr. Schechter has worked in several disciplines, including immunization program implementation and management, vaccine safety and post-marketing surveillance, vaccine communication, health information technology, immunization information systems, as well as vaccine research and development. So he has truly done it all. Dr. Schechter has had managerial and consultant roles for CDPH's immunization programs, which of course are amongst the nation's largest, including the California Vaccines for Children program, annually supporting 10 million eligible children. On a personal note, after working with Rob for a number of years, I can certainly attest to his encyclopedic vaccine knowledge base, but also his really kind demeanor. He is always so generous and patient with his time, which we know must be very limited these days. So without further ado, Doctors Pon and Schechter.
Great. Thank you so much, Dr. Singh. Good morning. And one minor clarification, I am no longer the acting state health officer, but I did do that from July through December 2020 during a slightly busy time. But thank you so much. It's really a pleasure to be here with all of you today. Many of you know, and you'll see from some of my discussion that vaccines are one of my just most important topics to me. And I think as a pediatric infectious disease specialist, it's just something, vaccines and immunizations are very near and dear to my heart. So I'll go ahead and launch in and provide a little kind of framework to get us started. Next slide. So I'm wondering how many people, this seems like such a long time ago, but how many people remember what year this was when we had a big measles outbreak in Disneyland? And people can put in the chat or, but this was actually 7 years ago, which seems like eons in COVID time, but there was a huge outbreak, as many of you may remember, of measles, which many of you also know we had thought we had been close to eliminating here in the United States. And as we've seen more vaccine hesitancy, we have seen more measles outbreaks. And certainly in California, linked back to Disneyland, we had over 130 cases in 2015. Next slide. And so as those measles cases increased and there was a lot more debate over vaccinations because certainly those initial cases were unvaccinated. Next slide. And then we had some champions from the Bay Area. There was Rhett Crowett, next slide, in Marin and Dr. Goldsby from UCSF, who really helped, explain and really went out there as a spokesperson for individuals who couldn't get vaccinated with a live virus vaccine and who need other people to be immunized till we could get to community immunity. Next slide. And then again, a lot of interesting sort of pushback on the vaccine anti-vax movement. Next slide. And so Senator Pan in that moment introduced a new bill to help improve school vaccination rates. Next slide. But I think harkening back to that time, and again, this is around 2015, and many of you, I think, who are vaccine advocates came and testified at these committee meetings during this legislation. And I think at that moment, we thought then there was a lot of anti-vaccine sentiment, but we also all knew that it was a really small proportion of the population. But I think the Capitol had never seen quite this many people crowding the Capitol, the long lines in these committees, and just crowding the Capitol hallways. Next slide. But thankfully, through all that, through some very long, very challenging weeks and months and long committee meetings, on June 30th, 2015, SB 277 became a law. Next slide. And then since then as well, other states also moved to remove personal belief exemptions to improve vaccination rates. So 29 states introduced vaccine bills in 2015. So we really had come from a time when there was a big outbreak, and there had been a slight increase in vaccine hesitancy, yet because of the measles outbreak, and really only 130 or so cases in the US, which seems like a really small number when you think about COVID, we had this real change and shift in movement and in legislation even to improve vaccine rates across the country. Next slide. And then what we saw in California was as we got rid of personal belief exemptions, we started to see more medical exemptions. And certainly many of us saw certain physicians who were not even primary care physicians, they were bariatric physicians and others writing these medical exemptions that were not actually valid for true contraindications to vaccines. So yet again, the anti-vaxxers really crowded the Capitol. I had the opportunity then to help testify with Senator Pan. Next slide. I think there's one more icon here. This was one photo you can see him sitting there during the hours and hours of testimony of the no's to this law, sitting there while we were waiting. Next slide. But again, thankfully that legislation also passed, and we have seen medical exemptions also decrease. So we went from 92 to 95% or so once we got rid of personal belief exemptions, and then really now have much stricter ways in place now so that medical exemptions are actually reviewed if there are multiple from one physician, and in schools with high medical exemption rates to really make sure they are for valid medical contraindications. And then fast forward, and that 276 was in 2019. And then the world has changed. Here we are a couple years into this pandemic, but 2020 really changed the world. And one thing I see when I looked at this icon of this graphic is some people really do see COVID-19 or SARS-CoV-2 virus as restricting the world in a way. And certainly they saw public health as restricting a lot of personal and individual rights as we tried to intervene to reduce transmission. Next slide. So one of the many kinds of things here, but this is really illustrative of, masks were required for a very long time. And of course, initially we had actually stay-at-home orders, and, the counterpart to that was really lots of protests about stay-at-home, mask, test, vaccine, even contract tracing. There was really kind of an increasing sentiment that was really anti-public health measures in general, including vaccines. Next slide. And sadly, I think over the course of the pandemic and comparing, this was an interesting survey. I think it was the Pew Trust here that comparing to, many over a decade ago in 2009 to now, trust in public health agencies has really eroded. Certainly for the CDC, you can see the decrease in state health department. It's harder to see here how local health departments fared, but thankfully some increase in trust in the FDA and the NIH, but you also see this decrease in the nation's public health system, and just a huge contrast even between April 2020, when we were still kind of trying to manage stay at home and figure out how to gradually reopen, to just a few months ago. You can see the decrease in trust in public health. Next slide. So I think this has also really challenged public health authorities. So as you all know, Biden attempted a federal vaccine requirement, and that was legally challenged. Most recently, a federal judge tried to eliminate the CDC's authority to require masks on public transit. So some things that we used to almost take for granted, and certainly in a state like California, where in general there's a lot more support for public health, we've seen, again, trust in public health and unfortunately, trust in vaccines really be eroded. Next slide. And since then as well, many states are now passing laws going in this other direction now to limit state authorities around public health emergency orders. And there are many states as well that are looking at getting rid of any kind of vaccine requirements in different settings. Next slide. And obviously, again, I know I'm preaching to the choir here, but we all know that a lot of this has really been magnified with social media and mis and disinformation and different kinds of influencers who have really magnified some of the myths and things that have decreased trust in vaccines overall. Next slide. But that being said, I think, some things to be really grateful for over the course of the pandemic are that we actually have relatively high rates. I remember in the beginning of 2021 when we were first rolling out vaccine, and I remember what Dr. Singh is mentioning when we had our community vaccine advisory committee, we had these goals and we wanted to get to, at least 75% of the population with at least one dose, and then that fully vaccinated at the time for primary series. And we have gotten there actually. So we have in our, mid-range 18 to 49-year-olds, we have over 78% of Californians have gotten their primary series, and even higher rates in the elderly, over 80% in our over 50 and 65. And those, of course, are the ones we want to protect the most. And our booster rates are actually quite high as well. Where we really need to move the dial is on children and pediatrics. So only 2/3 of our teens have gotten their primary series, and only 35% of our 5 to 11-year-olds. So we really need to move the dial even further on our kids and in pediatric vaccines. And we're all anticipating the under 5 to be rolled out soon if that gets approved. But I think this is where we still have a lot of work to do. And again, just restoring the trust in public health and vaccines overall. Next slide. So how are we going to do that? There's a lot of different ways, but I think some other key things have been really useful. I think a couple lessons, there's so many lessons learned from this pandemic, but we've demonstrated when you can resource public health, you can actually do so much. And so with the really robust Vaccinate All 58 vaccine campaign, we have promulgated values of using our data equity at the forefront. We actually allocated vaccines with an eye to equity early on in 2021, making sure we can do everything we can to reduce barriers to access and make things convenient for the community. Next slide. And then there's a lot of key tactics that our campaign is using that really are trying to get out there in the field, really work with trusted messengers, try to really understand how to address these access issues, and also, again, the mis and disinformation. So you can see here, there's 8 different components, 8 different teams that are working on all these different things, whether it's getting out in the field, having mobile clinics to meet people where they are, going to schools and doing school vaccine clinics, really having micro-targeted communications to specific populations to really try to get data as far as focus groups and surveys, and then use that data to inform communications, monitoring the mis and disinformation and trying to counter that, working with all of you as communities of practice to hear about, shared lessons learned, best practices that have really increased your vaccine rates in your communities, partnering with CBOs and others in neighborhoods, and really excited about our youth engagement partnership program with youth ambassadors. Really, it's all about trusted messengers, because again, I just showed you the data to show that public health professionals are not trusted as much anymore, and we really need people in communities to become our champions. And I think this will be true for all of our vaccines. And then also, of course, provider education. We're seeing some disturbing survey data as well that many pediatric providers are actually not recommended COVID-19 vaccine for their pediatric patients. So we really want to continue to increase and work on educating our partner providers. So really excited that you're all here today to join us to think about taking some of these lessons and expanding them to all vaccines. Next slide. Just quickly, I want to highlight that a tool that had actually been used for census tracking was created called the COVID-19 Outreach Rapid Deployment Tool. And it's really, again, using data and looking at equity to really think about how we do our outreach, how we look for gaps in access, how we look at equity, and really allowing us, again, to focus on that and use our data to inform our practices and allocations. So hopeful, again, that we can expand a lot of the tools and resources we used to broaden for other vaccine promotion. Next slide. And then, we want to continue to learn. So, I mean, it's been such a journey over the last 2 years. And even as I was harkening back and thinking about, how things have changed so much since that Disneyland outbreak, but really making sure we use that data and evidence, develop our messages, work on our outreach and education and access, partner with others, but then continue to monitor and learn and adjust, because as you all know too, the myths change, the issues change that are becoming barriers for people to get vaccinated or to get boosted. So continue to hope to have that cycle of feedback and really use all of these tools to improve our vaccination rates and continue to reach those who are most disproportionately impacted by many diseases. Next slide. So, and finally, in the end, it's all about hearts and minds, and that's true, I think, of the public, of policymakers, and everyone else. So really look forward to continue to work with all of you in the Immunization Coalition and all of our partners to continue to increase trust with hearts and show the data and evidence and the science and restore trust in science and public health and medicine and improve our vaccine rates overall. And with that, I will turn it over to Dr. Schechter. Thank you.
Thank you so much, Dr. Pond. That was a lot of information for all of us. Dr. Schechter.
Okay, Dr. Singh, can you hear me?
Yes, thank you.
Okay,
Welcome.
Thank you. As I'm shifting the slides over in my screen, and I will get my video going soon as well. Thank you so much to the coalition, to Dr. Singh, Catherine, Cameron, everyone for the opportunity to talk to you today. Following up on Dr. Pond's themes of the lessons of the pandemic and the mistrust and distrust that was in society going into the pandemic, and how the forces of the pandemic have exacerbated those issues around trust. Wanted to also talk about the profound implications of the pandemic, both in the problems created and the opportunities and solutions in the response to the pandemic. Let me get see if I can get the slides presentation mode. While this is toggling through, the next slide indicates that over the last year and a half, since December 2020, we have collectively administered in all your individual and collective efforts around California more than 76 million doses of COVID vaccine. And to put that in perspective, that's roughly 3 to 4 years worth of the influenza vaccine that's given in California each year. And as a result, let me go back out of stop sharing and seeing if the slides can come up. Apologize for the technical issues. My video is finally working, and let's see if I can get those
Dr.
slides
Schechter, would you like me to open them up for you?
Let me try one more time. Can you see them now?
Yes.
Okay. I'm gonna see if I can advance, or whether it's, apologies. Yeah, Cameron, let's please proceed.
Of course, no problem.
Bring them up. I will stop sharing. So 76 million doses given 3 to 4 years worth of flu vaccine, and achieving the higher rates that Dr. Pan was referring to, where over 70% of Californians have gotten a complete series, and over 80% have gotten one or more doses. Next slide, please. Representing immunizations at over 10,000 provider sites across the state, a phenomenal mobilization. Next slide, please. As a result, research at University of California, San Francisco of CDPH COVID case data, looking at it a couple of different ways, come across an estimate of over 20,000 deaths prevented by COVID immunization just in the months between December and October at the end of the Delta surge, not counting the large recent Omicron surge. Over 20,000 deaths prevented, a point at which I think can justifiably take collective great satisfaction in the public health benefits of all this tremendous, grueling effort. Next slide, please. Why have so many deaths been prevented? The vaccines work in preventing severe COVID. This slide of national data reprinted from the New York Times, contrasting the death rates at the peak of the Omicron surge over the winter, 156 deaths per 100,000 in persons 65 and older, compared with rates in those receiving their initial series down to 24 per 100,000, and those with a booster going down to 7 per 100,000. The vaccines are incredibly effective at preventing severe disease from COVID. Next slide. Along with the satisfaction in those results comes the sting of what might have been with higher rates of immunization. A study from Brown University and colleagues looking at what would have happened if rates had continued to increase above current levels up to 100% over the winter, and an estimated an additional 300,000 deaths nationwide. Fewer of those proportionally would have been in California, but still tens of thousands of deaths that could have been avoided. That's not to say that it's too late, and that our additional incremental work in delivering COVID vaccines still has the potential of preventing severe COVID in those who have not received their initial doses or those who haven't been boosted yet. Next slide, please. Dr. Pan showed these rates by age group, that the extremely high rates in adults, including those vulnerable adults 65 plus. I just wanted to point out that one feature of the pandemic has been the requirement that providers report all of their COVID vaccine doses into the state registry, CARE 2 and San Joaquin registries in California. And as a result, we've had unprecedented insight from the data into immunization coverage, and allowing us to look in all sorts of different directions. And as many commentators have mentioned, the pandemic, both in disease and immunization, reflecting divisions within American society, whether that's by location, by race, ethnicity, by class, socioeconomic status, by political affiliation. And here we see racial and ethnic differences in coverage, with African American and Latino populations in California having the lowest rates regardless of the age group, and the sharp contrast again between the rates in children and adolescents. Next slide, please. We've also been able to look at what's called the vaccine equity metric based on the California Healthy Places Index, a measurement of a community's social vulnerability and health metrics. And if you compare those who are most vulnerable in most vulnerable communities, the first quartile or VEM1, against those in the least vulnerable or most affluent, most advantaged communities, number 4, this looks at the difference between those extremes by age group in primary series immunization completion. From all those concerted efforts on a state, regional, and local level, with an eye towards equity, including those that you and your organizations have been working on, a fairly narrow gap for those who are older, for 50 plus, but looking at those who are most recently eligible, the 5 to 11s, not only do they have the lowest rates, but the most extreme gap between the haves and the have-nots. And if you were to look at a county level map, the county with the highest level rate for this age group in Marin County has immunization rates 75% higher than the counties with the lowest rates in California. Huge gaps, huge disparities. Next slide. So thinking about the immunization registry, where all this data has been located, has been entered, and then analyzed and mined carefully, with those 70 million doses, that's added to the existing data in the care system. So we're approaching nearly 500 million doses in the lower right-hand corner, 500 million doses of immunizations from all ages in the care system. Next slide, please. This is a map comparing 2006 with the current system. 16 years ago, the immunization registry system in California had 11 different county or regional databases. There were still 2 counties that were joining the system at a time, and now 16 years later, we have the latest update in the pandemic, where the San Diego Immunization Registry, or SDIR, over this spring, in the midst of all this craziness of the pandemic, has joined the CARE2 system. And we have these incredibly powerful increasing sharing of data within the systems, and the progress that's been made over the last 16 years. Next slide, please. The next slide shows a before picture of some of the systems that were there before the pandemic. In the lower left, you have those registry systems: CARE2, SDIR in San Diego, RIDE in San Joaquin area and Central Valley. You have data being entered about immunization and disease by local health departments into the registries and into the CalReady disease surveillance system. Next slide, please. And due to massive investments and a lot of work by the state of California, by the department, and a number of partners, have created a very complex and robust system for recording immunization systems, consolidating it statewide, reporting it to CDC. In the upper left, the creation of the MyCAVAC systems for providers, the MyTurn system for Californians to locate clinics close to them, and the ability to collect these millions and millions of doses and to analyze them. And these, as similar to Dr. Pan's comments, these investments during the pandemic to create these systems for COVID have the potential for application for routine vaccine as well. Next slide, please. Another IT development was the development of the digital vaccine record, again on a very fast pace with a lot of work, a lot of nights and weekends by state and affiliated contract employees. IT contractors developing a vaccine record in which Californians can easily access QR code to demonstrate vaccination, harnessing the information in the registry. Next slide, please. And as the last bullet shows, the creation of this record for COVID vaccine is a prototype for creating for consumer access to immunization records for all vaccines. And this is work in progress, so that the department is working on to expand the application of this to routine immunizations over the next year. Next slide, please. Now, again, a contrast between COVID vaccine and routine vaccines is that COVID vaccines are required by federal contract. If you get the free federal vaccine, you've got to report the doses into the registry. In contrast to routine immunization, which is currently optional for most of us, except for pharmacists such as Dr. Goad and Dr. Hogue will be speaking later. Pharmacists have to report to the registry. Everybody else, it's optional. This would change under a proposed Assembly Bill 1797 from Dr. Weber down in San Diego. If passed, then this would require healthcare providers and other agencies to enter immunization data into the registry and to harness the same kind of potential that we've had for COVID vaccine for all vaccines. Next slide, please. So right now, for the 5 and aboves, where the current landscape is routine initial doses, first boosters for everybody 5 and older, second boosters recommended for a subset of those 50 years and older or who are immunocompromised. What about the under 5s? Over the next week, data that's just been submitted by Pfizer and Moderna to FDA will be reviewed carefully for possible authorization and recommendation. Next slide, please. I want to just talk for a second about the common misperception that COVID is an innocuous disease for children, whether under 5 or in the primary school or secondary school ages. This flyer for providers to help providers in their conversations with families is on the EZIZ website and emphasizes the potential severity and the comparable severity of COVID to other diseases we worry a lot about. Next slide, please. A recent preprint looks at US data and the ranking of COVID over the last 2 years as a cause of death in age groups during childhood and adolescence. And as you can see, as a general principle, children and adolescents have lower rates of mortality. They have fewer deaths. But regardless of age, COVID is an important cause of mortality as well as severe morbidity in childhood. Next slide, please. As another point of comparison, if you look at other vaccine preventable diseases, this slide shown at the ACIP meeting recently around childhood vaccine and boosters for the 5 to 11 years old makes the point that if you look at the other diseases, we worry a lot about severe disease in kid, meningococcal disease, chickenpox, rotavirus. The number of deaths in the United States due to these diseases before the availability of universal vaccine was on the same level, if not lower, than the death we've seen the last few years from COVID vaccine. Similar statistics around hospitalization. Next slide, please. So this is the calendar for the next few weeks about the review and potential availability of vaccine for under 5s. Next Tuesday and Wednesday, Dr. Mark Sawyer and other members of the FDA Advisory Committee will be looking at reviewing the data presented by the manufacturers on the safety and efficacy of vaccine for children younger than 5, as well as Moderna vaccine for older kids. A few days later, the Advisory Committee on Immunization Practices, including Dr. Oliver Brooks, will be reviewing these vaccines for possible recommendations. If the vaccines are authorized and recommended, shipments will arrive the week of June 20th for initiation of vaccine for this age group. One more meeting of the FDA Advisory Committee on the 28th. We'll be looking at the important issue of, do the vaccines need to change and when do they need to change? How sustained is the protection against severe COVID from our current vaccines that have done such an amazing job so far? And when do they need to be changed, and how should they be changed with perhaps other variants to keep protecting us against the variants that we may face over the next years? Next slide, please. This briefly compares and contrasts Pfizer Moderna vaccines for childhood age groups, and noticing for the under 5 or under 6-year-olds that for Pfizer and Moderna, there's different age cutoffs. At all these ages, there's different dose volumes. And for the young kids, there's a different number of doses that are likely for the primary series. And these are factors that providers and families may be coming to you with and thinking about as they making choices for their kids. Next slide, please. What is the initial demand for the vaccine under 5? This is Kaiser Family Foundation, April 2022 survey data looking at parental interest in immunization, either immunization that's already happened in the older groups or potential immunization for those not yet immunized. And in the under 5 groups, have over 50% of parents saying that they're in the right away, the early adopter category on the left hand, or the wait and see, that they are amenable to considering vaccination. And so a possible reflection of a wave of early adopters coming to you for those under 5 vaccines, plus a longer game of counseling, providing information, listening to concerns, in getting another 30 or 40% of parents to getting their parents immunized over the next months. Meanwhile, for the older kids and for older adults, there's similar survey data that suggests for those who have not been immunized or fully immunized yet, there still are a number of children and adults who where they're considering the possibility of immunization, and your continued efforts will be crucial to reduce the burden of the pandemic and to continue to prevent severe disease. Next slide, please. Shifting from COVID vaccine to routine immunization, I've shown this type of graph a lot over the last couple of years. This compares immunization before and during the pandemic. The gray background area shows the number of MMR doses, second doses given to kids about to enter kindergarten or pre-kindergarten in California per week, the number of doses per week entered into the registry. The red line, the red dotted line, shows what happened in the 2020, and in the spring and summer of 2020, a lot of deferred immunization by families and providers during those early months and lockdown. In contrast, in 2021 and 2022, the blue and black lines, rates have gone up to close to what they were before the pandemic, but have not been able to fill that gap, which for MMR vaccine in this age group may be as many as 1 in 6 kids in California within that cohort. We'll call your attention also to the beginning of 2022 and how the black line is lower than the gray line, and that may reflect more deferred immunization at a smaller scale during the Omicron surge. Next slide, please. This is similar data showing comparing immunization numbers of doses and care for routine vaccines, non-COVID vaccines, non-flu vaccines, all the other vaccines combined for different age groups, and a pattern where higher levels were maintained, not 100%, but higher levels were maintained in the infants and toddlers. And as you get out into adulthood, much lower rates to exacerbate a situation where adult immunization rates were low to begin with. Next slide, please. On this theme, call your attention to proposals in the White House budget for the fiscal year, for the federal budget in 2023, proposal for a new vaccine for adults program that would provide all ACIP recommended routine immunizations to uninsured adults at no cost, and a separate proposal to move the vaccines currently covered in Medicare Part D for older adults in which Part D, the pharmacy benefit, which includes co-payments or charges, to move them over to Part B, where influenza and pneumococcal vaccine are, which do not include such co-payments or charges. Next slide, please. On that theme of Medicare Part B versus Part D, this is immunization coverage rates in age 65 plus reported to CDC, contrasting the higher rates in influenza and pneumococcal vaccines covered by Part B with rates for shingles and Tdap vaccine, which are currently covered in Part D, and the possibility that removing some of the financial barriers would help to close some of these gaps and raise rates in adults. Thank you. Next slide, please. In thinking about the implications of deferred and delayed immunization during the pandemic, I want to divert your attention for a moment to the ongoing outbreak over the last few weeks of monkeypox, in which over 1,000 cases have been detected in 24 countries, primarily in Western Europe. If you look at the virus strain that's causing these cases, it is very closely related to cases in recent strains in recent years from cases in Western Africa, Nigeria, and adjacent countries, suggesting that this large worldwide outbreak, growing rapidly, may have been triggered by travel between Europe and Africa, and then introduction into susceptible populations around the world. And then using some of those themes about increased global travel as restrictions have loosened in recent months, and susceptible populations, carrying those themes over to the next slide. and the topic of measles. In April, UNICEF and WHO issuing a warning about measles outbreaks, that cases are up 80% in the first part of 2022 compared to 2021, noting the disruptions to global immunization, not only in California, but to a greater degree worldwide, diversion of resources from routine immunization to the immediate concern of the COVID response, relaxation in recent months of measures to prevent the spread of respiratory diseases, such as a secondary effect of relaxing against COVID, and then disruption caused by conflict in Ukraine, the Horn of Africa, Afghanistan, displacing millions, and disruption in healthcare. As a result, next slide, some of the countries in which there's been the highest case rates, cases per million, include these zones of conflict. But I also want to call your attention to the number 4 highest case rate in Nigeria, the same area where monkeypox has been, there've been local spread of monkeypox and introduction and exportation through international travel. Has also had a high number of measles cases in the last 12 months. While none of these 5 countries have are the highest levels of travel to the United States compared to Europe or Asia, India, which does have more frequent travel links to the United States, has also reported a number of measles cases as well. Again, setting up a situation with lower immunization rates for if there is an introduction of measles from travel, that there are more vulnerable children to continue the spread of the disease than there were before the pandemic. Next slide, please. And then thinking again about the ongoing risk of importation and spread within the United States and international spread of COVID variants. This is a virus that continues to evolve rapidly. And as we look at the sequence of variants of SARS-CoV-2, the most recent variants on the right-hand side in dark blue, first being detected in high numbers in New York State. In yellow, the BA4 and BA5 variants, which are being seen in Southern Africa. The lessons here that the virus is mutating around the world. New variants that could be less well matched, which the vaccine has less protection against, could emerge. And the importance of local, regional, national, and global immunization in protecting us, and hopefully also trying to slow the speed of emergence of these variants. Next slide, please. My last point, call your attention to Dr. Eric Topol at UCSD, who in recent weeks has been advocating for Operation Warp Speed-like efforts, noting the incredible effort within 1 year, about 12 months from the emergence of the virus, to having millions of doses of vaccines that work incredibly well against severe COVID, and that continued sustained efforts on this theme of research and development could bring us new generation vaccines that might do a better job of having broad protection against current and future variants, or by protecting against milder disease through mucosal immunity. And my last concluding slide. So to recap some of the themes, I hope to thank you again in gratitude for the lives saved, the people kept out of the hospital, for all the work your efforts have done with COVID immunization and continue to do around routine immunization, our ongoing challenges in addressing inequities and rebuilding trust, combating misinformation, the tremendous opportunities from coming out of the pandemic in the role of IT systems, in funding initiatives, and in public large-scale investments in next generation vaccines. Thank you for your time and interest and all your hard work, and a picture of cute kids on the next slide to close us out. Thank you.
Thank you so much, Drs. Pon and Schechter. That was an amazing amount of information for us. Really appreciate it. We have time for a few questions. So I'm going to start the first one for Dr. Pon. This question is from Dr. Hogue. And the question is that with the data you shared, you mentioned that many pediatricians are not recommending COVID vaccines. Education of providers is key, as was mentioned, but what other strategies do you suggest for ensuring children are vaccinated in the meantime, given the impending likely approval and recommendations?
Yeah, great question. I think a lot of what we talked about are key as far as working with community partners. I'd say a lot of our state efforts include, again, having these mobile clinics, mobile van, we're calling our mobile clinic blitz, and actually partnering with, food trucks and community-based organizations to really, again, meet people where they are in the community, partner with trusted community leaders. And we're also doing a lot to work with childcare centers and community organizations to offer clinics for young children, knowing that a lot of our smaller VFC providers have not yet enrolled to administer COVID-19 vaccine. We're doing a lot of kind of outreach as far as phone banking as well, to kind of reach out to families and answer questions about vaccines. Other things called our mobile tour edutainment, so having family-friendly tour locations, so at fairs and festivals, and creating interactive and educational experiences that give education about the safety and importance of the vaccine. So those are some of the efforts. I think it really is going to take efforts at all levels, though. I think we all know every dose counts, and I think if you have other ideas or other efforts in your communities, we certainly want to know and hear about them. And I think we're all going to need to really, as the data Dr. Schechter showed as well, of the very low proportion of parents of under 5s that are interested in right away is really striking. And I think we're all going to need to work very hard to figure out how to get trust in parents for the under 5s as well. Thanks.
Yes, thank you. I was struck by that data as well, and also so helpful to have the data that you showed about the impact on children, which I've certainly seen in the hospital, but there is a perception out there that this is just a very benign kind of a cold illness. We're seeing several misses this week, and this is not benign in these kids, that's for sure. So thank you for that. The next question is for Rob. Dr. Schechter, could you speak a little bit more about the legislation you mentioned, which could make routine vaccinations required to be inputted into the national registry? Is this legislation being discussed on the national level or the state level in California?
So the State Assembly Bill 1787 is in the California legislature, and would make a couple of big changes in the law around the California registry, including a requirement to report all doses of vaccines, not just COVID vaccine, a law which some states have, and other states are like California, where it's voluntary. There are discussions, certainly COVID vaccine has been analyzed, and the importance of COVID vaccine on a national scale has been appreciated. And the fact that we've, as you saw on the state map back in 2006, we went from local systems to a state system. And so there's also been parallel discussions about connecting state registries for national level data. But I'm not aware of national legislation in Congress at this point. But AB 1787 is under active debate in Sacramento at the moment.
Thank you. We are almost out of time, so I'll ask one last question to both of you. What is the greatest learning point you've garnered from this pandemic experience regarding public health implementation of a new vaccine program? The one greatest learning point for each of you. I'll start with you, Dr. Pon.
Wow, that's a big question. I think one of the biggest lessons we learned was that, honestly, and Rob actually emphasized this, but our data systems are so crucial. I think we thought we weren't getting vaccine out when we didn't have the data, and it took us too long to get that data. So really glad that this bill is in conversation for other vaccine efforts as well. and just how decentralized both our public health and medical systems and health systems are, I think were certainly magnified during this pandemic. So that's my answer. I think the importance of really getting data to improve implementation.
Yes, thank you. Rob?
I'm struck by there's been the comment over the years that it's not enough to have the vaccine, as opposed to you can develop a vaccine in 12 months and it's only as good as people's willingness to receive it. And it just torn between the exceptional outcomes of those who receive the vaccine and the tragic cost of where the vaccine of those who have declined or haven't had access to the vaccine. And so very humbling about the combination of technology, healthcare delivery, and sociology, psychology, all these factors that all need to come together to keep us protected.
Thank you so much. Well, I was certainly saddened to see the data about the erosion of trust in public health, but I think I speak for everyone on this call when I say that we certainly appreciate the two of you, as well as everyone at CDPH, for all this incredible work. So thank you again. And we are going to be moving over to our next session